I want to thank you all for having me today. It's really an honor to be able to share our experiences with COVID-19 really over the past couple of months now. And we've had really so much occur over the time period. It's been a time of great uncertainty with our department, and our team has been stretched in so many ways that we really could have never imagined this before. In emergency medicine, we really practice by this mantra of anyone, anything, anytime. And we're all very well trained and used to caring for severely ill patients, and really any patients who enter our doors, no matter time of day and with any condition, whether it's chest pain, gunshot wound, broken bone, it doesn't matter. But I'll say that as being an emergency physician for over the past 20 years, I've really never seen anything like this before. There's just been such a heightened level of anxiety that's surrounded COVID-19. Much of it, I think, due to the many early unknowns about the disease and concerns regarding limited testing, supplies, personal protective equipment, just many other challenges. So I want to highlight some of these challenges that we face and some of the innovations that have occurred through our department. Maybe just for all of you who may not know as much about our department, we are a brand new academic department at Columbia from approximately 2 years ago. We actually have 4 emergency departments, 4 emergency rooms, if you will. The Milstein at 168th Street, our Morgan Stanley Children's Hospital. We have the Allen Hospital up at 215th and Inwood, and then the Lawrence Hospital in Bronxville and Westchester. So those are our 4 clinical sites where we see patients. To staff this, we have about 117 faculty members who are full-time, 38 physician assistants. Our trainees, we have 48 residents. Our residency program is actually by campus and so shared with Cornell. And then we have 12 fellows here at Columbia. So that's our at least on our provider side. And at these 4 sites, we see approximately 250,000 patients per year. So it's about 700 patients a day, 7 days a week, obviously. And I would say that certainly we have a little bit of a higher patient volume and also acuity in the winter time, certainly when we see lots of other viruses as well. So just talking a little bit about, as we started to think about in early March, we were at a very high volumes. We were still in the, on the tail end, but still very high with flu season. We had lots of patients, I think, routinely boarding in our emergency department, which means that there aren't beds available in the hospital. Sorry about that. And so the patients end up completing their emergency department evaluation, but as they're waiting for a bed on the inpatient services, still stay in our space, which means that it just causes more pressures. The nurses, physicians are still caring for these patients, but obviously our doors are open and people still entering. So as the community demand began to grow due to symptoms from COVID-19, we started trying to think about how are we going to deal with all these patients? And initially our volumes were very high. So a number of things. I think our department has always been very used to using telehealth. We use it in a lot of innovative ways, but we very quickly, with partnership with NYP, it's a NYP platform that we, as well as the emergency medicine department at Cornell Medicine, staff telehealth. And so this was ramped up even more. We added more providers, and this is a virtual urgent care, if you will. So any of you can download an app on your phone and access one of our emergency physicians. Something that was very innovative, if we have both emergency medicine physicians and we also have our pediatric emergency medicine physician specialists. And our pediatric group was not as busy as you all have heard. This disease really has hit hard on adult patients and not so much on pediatrics. And so we were having our pediatric providers not seeing a lot of patients, our adults physicians seeing many more. So our pediatric group started seeing some young adults specifically with COVID-19. And as folks started getting more and more comfortable with this, we're actually seeing almost all ages with COVID-19, and certainly being able to utilize our emergency medicine faculty as well. NYP also started a hotline, which we found incredibly helpful for folks who just had general questions or trying to figure out when to come to the hospital. And then again, with lots of partnership, and you're going to hear that word a lot because obviously with emergency medicine, we touch everyone in the university and health system as far as the medical world. So partnered with the ambulatory physicians, primary care physicians, et cetera, to work on tents. So if you've probably noticed outside of all the emergency departments, there have been tents that have been placed, and these really were to help take the patients who were the least sick, less acuity, and be able to see them in the tent. So we stationed folks right outside the emergency departments to screen, and if they met certain screening criteria, could be able to be brought in the tents. And that was a huge aid in being able to keep the less sick patients out of the emergency department and seen in these tents, which were running anywhere from 10 a.m. to 6 p.m. and at sometimes 10 a.m. to 10 p.m. We also worked on other ways to divert the less sick patients out of the emergency department, knowing that this disease presents in various ways, various presentations. People can have minimal things like sore throat, runny nose, and a little bit of a cough, all the way to being very hypoxic or have low oxygen levels and needed to be on a ventilator, intubated, in the intensive care unit. So obviously wanting to keep the space that we have in our emergency departments for the more sick patients. So working on partnering with different services. So as you know, elective surgeries were canceled at the hospital. And because of this, many of our surgical colleagues had time and were not seeing patients, right? In the operating room, they weren't doing knee replacements, et cetera. So because of that, we were able to screen patients, and if they had isolated orthopedic problems, pains, injuries that we normally all take care of in the emergency department, we actually diverted them and escorted them to a clinic area where our orthopedic friends or gynecologists, et cetera, could see some of these very isolated patients. Internally in the ED, again, we were suffering a lot of boarding, a lot of patients in our spaces. At 168th Street, our emergency department is very large. We have easily 90 bays where we can see patients. But despite that, and this is, of course, what has been going on all winter, just with our flu season as well, we were having patients in the hallways. And certainly, as you can imagine, with something that is communicable, like this and does spread, it's challenging to have folks in the hallway. And so, I think early on with our PPE, where we're following CDC guidelines, but we didn't quite understand the community spread. As that grew and as our understanding of the disease process in the community began to develop, we realized that, it was far more widespread than we knew. And so at that point, then all patients were having masks placed, et cetera. But again, having patients in the hallways and things is still really a challenge, especially when they're requiring oxygen care. So again, we tried to think about alternative care space, how we can use our space differently. So everything from utilizing our front end of our emergency department is usually for less sick patients. And those rooms are not equipped with oxygen or telemetry monitors, et cetera. And so very quickly with NYP facilities, we're able to turn those rooms into rooms that we could take care of sicker patients. We took our very large waiting area space and put up barriers and constructed makeshift rooms, if you will, so we could still see the lower, less sick patients out in the waiting room. So again, we really, I don't want to say doubled, but almost doubled our capacity in the emergency department and tried to keep people out of hallways and get them into more private spaces. One of the other very innovative things I think we started to do was we've noticed a drastic reduction in the amount of patients, pediatric patients that we were caring for at our children's hospital. If we normally see, say, 200 patients a day, we were seeing only 25 pediatric patients a day. So really significant drop in our pediatric patients and families who were coming. So we started screening our younger adults up to age 35. And if they were stable, we walked them the half a block over to our pediatric emergency department. And still that's ongoing. And a lot of these things are still ongoing. So again, thinking about how we do that. In the height of this, which I would say was about 3 weeks ago now, we had many, many deaths and many intubations and critically ill patients in our emergency department. So just on a typical day.
Angela, this is your 1 minute mark.
Oh, 1 minute, really? Oh boy. I thought we were doing 20 minutes. but maybe I'm wrong. Longer than 10?
Andrea, we gave Angela extra time, I believe.
Fantastic. Okay, so
Got it.
forget
Okay.
about it. I'll give you another
I'll go
reminder.
faster. So much
Yeah,
to say.
until 9:05, I think.
Yeah. Anyway, we developed an ED intensive care area. So really put a whole intensive care unit in our emergency department. We're able to bring our intensivist colleagues down there, which has been significantly helping. Just a little bit about staffing. I'll just say that early on, due to, like I said, not knowing patients were positive, we were having significant amounts of our staffing out on quarantine. Initially, people were out if they were just exposed to COVID-19, even if they had no symptoms. And so at one point, we had 20% of our physician staff and providers out. So this was a significant challenge for us. But as those recommendations changed, we were able to bring people back quickly. But again, we had to be flexible and be able to utilize folks. So when people were out in quarantine and didn't have symptoms and felt well, they actually could work, they worked telehealth from home. So I think that was great. I think, again, one of the challenges we had was limited testing, which is still very limited. We've really only been able to test patients who are being admitted to the hospital. So as you can imagine, that adds a lot of stress, anxiety, patients who are sent home, and we assume they have COVID-19 and gave them instructions as so, but not clear whether they really did or not. We also had challenges with our visitor policy. As you know, the hospital correctly made a visitor policy where patients were not allowed to have people there. But as you can imagine, a lot of these patients were very ill, sick. English is not the primary language for at least half of our patients that we take care of. And to be able to discuss end-of-life issues, goals of care, we had to be very creative with having iPads and FaceTiming, using WhatsApp, et cetera, with patients. Another area that we developed really greatly was palliative care, which normally we don't have access to in our emergency departments. But palliative care came and was pretty much stationed in our department, was able to see patients and families remotely. You know, there's been a lot of talk about personal protective equipment, masks, et cetera. I think initially the biggest thing I can say is that it was being taken, you know, whether by patients, by staff, or by folks from other parts of the hospital. They would come down to the ED and grab handfuls and leave. And so we were often left looking for PPE. So we quickly put our PPE under surveillance and, you know, had to make sure that it was in a locked room or that, you know, certain people had access to it. So while it was a little bit frustrating, we needed to do that to make sure that we had appropriate amounts for everyone. I will say we've gotten tremendous amounts of donations, 3D printing, and that's been really, truly a full-time job. Some of the things that we're getting maybe weren't compliant, donations, et cetera. So that's been a big challenge for us to be able to manage. Ventilators, again, added to the anxiety. Everyone was worried we were going to run out, but I would say that the hospital was really successful in obtaining lots of ventilators, and so that has never been an issue or a challenge. Some of the great collaborations that we want to continue is care pathways. We've been having nightly calls with the 9 emergency departments within the NYP system, with Cornell, Brooklyn, Hudson Valley, Queens. And with those groups, we come together and done a lot of evidence-based medicine and put together care pathways, everything from care from mild, moderate, severe illness, those with asthma. We put together palliative care pathway. One of the other things that we've done, because we had limited resources with beds and personnel, was try to figure out who we could potentially send home, folks that we don't normally send home. And so we were able to send people home with a pulse oximeter to measure oxygen levels at home, as well as with oxygen concentrators, which usually there's just tremendous challenges with that to send home, whether it's insurance, follow-up, et cetera. And all of these patients have been getting robust follow-up with many phone calls and telehealth. And to go into telehealth, this was created by our telehealth team here, who's been amazing, really trying to think about how we are short people, protective equipment, space, patient needs, and match our telehealth. So this is a picture in our emergency department when we set up a nurse-free model where patients could go in and self-access, almost like a kiosk, and obtain telehealth providers. So again, trying to be creative with our constraints that we had. Same thing with communication. We found that there was a lot of stress, anxiety, a lot of tragedy and trauma that people were seeing. And so be able to adequately communicate with our folks. We did frequent huddles, obviously by Zoom, virtual huddles with our faculty. At times we invited guests, whether it was infectious disease or other folks, to be able to answer questions. And a place for people to share and express concerns. Also daily emails that we limited to from one person in the department who was sending those out to both of our groups. And so that, I think, was very helpful to be able to provide information and hopefully allay some of the fears, but also make great suggestions and move forward with that. I think this has been, as I said, very trying on all of our frontline providers. Like I said, people are just seeing an unwitnessed amount of deaths, of intubations, of critically ill patients. So thinking about wellness, we partnered with our Department of Psychiatry and have been able to offer Zoom peer-to-peer mentoring type sessions, as well as one-on-one sessions for mental health if needed. Our physicians and providers and staff and everyone work anywhere from 8 to 12-hour shifts, which often spill over 13, 14 hours and can be very long days. And with the amount of PPE and infection, there really was no space for folks to eat with social distancing, et cetera. So we developed a lounge. We provided gift bags for everybody with a set of goggles and a pulse oximeter, et cetera, for our providers. We've had tremendous amounts of donations, just food being delivered from restaurants. Obviously, the hospital's also providing food bags, et cetera, meals for our providers. So that's been a huge relief for people. Our staff was amazing and did some sidewalk art, and we've been very lucky to have an amazing hairstylist come in and offer free services for haircuts for people. So it's all these little things that I think can add to the wellness of our folks. So I would end and just say that as much tragedy, illness, and trauma that we've been seeing with COVID-19, there's also been so many really heartwarming acts of kindness, collaboration, really support for the emergency department, for all of our frontline workers. I do worry about all the downstream effects of mental health outcomes that are yet to be seen. I know from other countries that we're seeing large numbers of folks who are not returning back to healthcare jobs and positions. And so that's a big worry, concern for me, as well as potential continued medical illness and spikes in illness. I think there's still more to come. So again, I want to thank everybody, and I'm happy to take questions if there's any time.
Thank you, Angela. Sorry for the interruptions. I was not aware that it was a 20-minute talk. So as usual, and I just wanted to mention to anyone, we have right now about 500 attendees. So even in fourth edition, remains an extremely popular venue, and people remain very interested. So if there are questions for Angela, it would be great if the attendees could raise their hands and I can promote them and let them speak. And I don't know whether any of the panelists can also ask questions.
Angela, this is Andy. I have a question. You mentioned testing. Do you have an estimate of how many tests you optimally would need to do in a day? And Kevin Roth has indicated that there's excess capacity. So I'm wondering where the issue is with getting testing.
Sure. Yeah, so, and I guess I didn't mention, but normally in our emergency departments, I told you we saw 250,000 patients a year. We admit about 20% of those. So the vast majority, 80%, we send home. With this COVID, on some days and weeks, we were admitting up to 50% of our patients. But again, all the patients who are not being admitted are not being tested. So I think that group really would benefit from testing. Right now, our volumes have been lower. I would say anywhere from 200 to 250 patients a day that are going home who are not being tested. And I think that would be a tremendous group to be able to test. And we are seeing many of those patients either potentially return or even return somewhere in our system, if not to our emergency department, but to the primary care providers, either with continued symptoms, et cetera. So I think it would be helpful to test.
There is a question by Stuart Firestein. Stuart?
Hi, thanks, Andrea. Angela, I was just curious as to whether you in any way routinely or otherwise ask patients whether they've lost their sense of smell. As you know, anecdotally, that's been reported, but we now have some pretty good numbers on it. And there's also a report not yet published to come out of UCSD in which they seem to suggest that patients who have lost their sense of smell and report that tend to be on the milder or moderate symptomology side. So I'm wondering if that's a potential one of many ways of triaging patients.
Yeah, we absolutely do ask for a sense of smell and even sense of taste. I think you know, the long list. I think that's one of the interesting things. Initially, we were, I guess, relieved or not as concerned when a patient would come in and have an obvious appendicitis. But we very quickly found that patients with acute appendicitis also were testing positive, or patients who were older who passed out for other reasons and hurt their neck. Would also test positive, and we were admitting them for something else, for a broken bone. But we have been screening for all of those things. I can share personally, I was pretty sick for a couple of weeks with COVID-19 myself, and not only lost my sense of smell, but it's been, I'm gonna say it's been 6 weeks since I first started with a sore throat, cough, etc. And I still don't have my sense of smell completely back. So yeah, it certainly is real, and we are seeing it.
Rita?
Angela, thanks for that great presentation. There's so much now in the public media about the day in the life of the emergency room physician and things like that. Do you think we're being well served by the word going out public, or are you concerned about the ways in which we're being portrayed?
Well, I think, you know, I think the challenge that I see is that across our city, there are different resources available to different emergency departments, and certainly even the areas. Queens really has been very hard hit, you know, followed I think by the Bronx, and we do see a lot of patients from the Bronx. So even when you look at our NYP emergency departments, those in Queens have had different patient presentations, and just their numbers and volumes have been higher. And then you go to resources available for the hospitals, you know, whether it's the city hospitals, et cetera. And so, you know, I think it's a challenge. I think the anxiety and the unknown of this disease, and the unknown of, will we run out of ventilators? Will I be forced to make a decision of who lives or dies, that, you know, I intubate this patient or not? That's been weighing very heavily, I think, on emergency providers. And I think with that, folks have been sharing their stories, which have been obviously very personal and different depending on where people work. I'll say within our system here, we've been extremely well supported and well resourced, et cetera, to be able to take care of our patients appropriately. But certainly there's a lot of trauma and tragedy around this disease, which I think has been hard hit for the providers.
Let me ask you a question, Angela. So there's been some controversy around sort of clinical trials that have been run without appropriate control arms. For instance, you know, the remdesivir study really showing some potentially positive results, but in the absence of a control arm, it's impossible to really draw a conclusion. So how are we dealing with, so you mentioned before the symposium started, that many patients that come to ICU are put on clinical trials-based treatment, and do we have appropriate control arm in place for those studies?
Yeah, I mean, I do think that is a challenge. I think number one, until we get to universal testing, or the ability to have testing of all patients, you know, that's a challenge. It's still difficult to figure out what the true sensitivity and specificity of these tests are. I think we're all seeing patients who test negative but are very clearly COVID-19 and could be nothing else. And of course, some of it's anecdotal, and I know that there's been a lot of tests done and you know, controls done with the lab, but there are still those challenges. So I think until we get there, it's hard to have control arms. But certainly right now in the emergency department, folks who are well enough to go home, other than oxygen and supportive care, monitoring, follow-up, we are not starting any treatment. Those obviously being admitted to the inpatient are being randomized. So I guess I don't know all the specifics of all of those studies and whether they are randomized people to either get the treatment or not, and using those folks as a control arm. But it does leave a large group of patients who are not being included in controls, right? Those who are either not sick enough to qualify for the study, or those who are being sent home without the testing. So I think there's a lot of data that's still unknown and work to do.
Yeah, but those controls would not be sort of matched to the demographics and to the actual severity of the disease that the people that are being treated. So there will be several confounding factors that would need to be accounted for.
Yeah.
Andrea, I have two questions.
Yeah, go ahead,
To
Andy.
follow up on the presumed false negative tests, Angela, uh, have you had a chance to test those people more than once, and have they been false negatives twice, which would be scientifically very improbable? And then I have another question.
Yeah, that's a great question. I don't know that I have good data. I do think anecdotally I have heard that because obviously the test takes a while to come back, and by the time we're on a second test, they're usually upstairs. But I have heard the inpatient teams are sending even 2 and sometimes three tests because they're very concerned that there's really nothing else this patient could have. So again, I don't know the numbers, and maybe it's 1 or 2. We have PCR tests, but we also have the rapid point of care testing as well at one of our EDs. So we are seeing some differences there. Again, I think it's expected that there are going to be some false negatives, but at least anecdotally, it just seems that they're a little bit higher than what we're used to with much of the testing that we perform.
And then there's a question from an anonymous person in the Q&A. As the hospital prepares to reopen and we plan ahead for the fall, what are you most worried about for the next wave of this crisis?
Yeah, I do worry that New Yorkers will start to hear positive news and maybe go out and not social distance, and that we will have continued spikes. With cancellation of outpatient procedures, we've had many redeployed folks who have been able to assist and help, and certainly the volumes have been very maintained, and we're able to provide better care. But as those things change, I just worry we're going to end up in the same predicament again. I also worry about our frontline staff. I think while we as a group are incredibly resilient and have lots of grit and courage, I do see some signs of some mental health challenges, or folks who are really having some challenges. So I worry about that as well, not just for emergency medicine, but just across our system, and certainly those who are continuing to work. While in the ED, we've seen a decreased numbers, or certainly our intensive care units are still working just as hard, and we've seen that patients, on weeks, have been in the hospital for weeks, and obviously have lots of complications, whether it's renal, et cetera, challenges. And so how are we going to manage this chronic illness as a system? And again, patients hopefully will start to trickle in, because we've been seeing low numbers of patients with other diseases. And, and the big talk has been, where have all those patients gone, right? Where have our children with abdominal pain gone? Where have our strokes gone? Where have all these patients gone? I think some of them obviously are being managed maybe at home over the phone by their primary care doctors. Some, I think, unfortunately don't have the great access to care and might be dying at home and are part of this, a lot of the deaths who obviously we're not even seeing and aren't even being transported to the hospital.
We have a question from Neville Kleins.
Yeah, hi. I was wondering whether you foresee for the whole summer, basically assuming that all patients who are coming in are COVID positive and having to use PPE for all patients, or whether you're hoping to have testing at such a level and rapidity that you'll be able to avoid that.
Yes, I would say both, in the sense that right now we are still continuing our PPE, and I suspect that will be for some time now. I agree that I think universal testing is going to be imperative, just to see what the numbers are, what the community spread is going to be like before we can, eliminate PPE or eliminate masks. But at the same time, we're also trying to think about ways right now of restructuring our emergency department. So maybe I don't want to say COVID-free and COVID areas, but at least a lower risk COVID versus COVID. And certainly patients can certainly be asymptomatic carriers, but still be positive. And hopefully they wouldn't be shedding as much, but might be presenting for their abdominal pain, for appendicitis, or whatever the case may be. So I think testing is going to be a critical aspect in that decision making.
We have a question from Janine Darmiento.
Yes, I'm just wondering what percentage of your faculty and staff became ill with COVID in the last 2 months?
That's a great question. I don't have, I'm sorry, I don't have the exact numbers with me right now. I would say early on, we had 20% out, but again, some of that was with exposure and weren't symptomatic. So I would say it's more probably in the 5% range or smaller. And I apologize, I don't have an exact number, but you know, at some point also, just so you all understand, there's limitations because we weren't testing our healthcare workers either. So many folks had symptoms and it was unclear, do they have another virus? Do they have allergies? So we really don't have a great number, unfortunately. Recently, we've started having the availability to be able to test all healthcare workers, but we have limited data around that.
And then one last question from Margaret Crosby Arnold.
Hello?
Yeah. I
Hi.
can hear you.
Hi, how are you? Listen, thank you so much for your talk. You know, you're on the front lines of seeing some of the disparate impacts in terms of death in COVID-19. And I was just wondering if you have any thoughts about what more can be done to reach out to these communities, either from the city's perspective or just from a community outreach perspective, or, you know, what are you seeing and what do you think needs to be done?
Yeah, that's a really great question. Thank you. We do take care, you know, in Washington Heights, Inwood, of a patient population with a lower socioeconomic class and some limited access to healthcare. And like I said, at least about 50% of our patients, English is not their first language. So I think more messaging about the updates, both in English, Spanish, and other languages, depending on the communities. But certainly in our community, it's Spanish and English are the big ones. You know, ways to access care, making sure that patients do recognize it is safe to come to the emergency department, that we're taking all the precautions. I think that's a big one. I'm hoping that we can get back to allowing visitors. I think that's another challenge is patients, families are very reluctant to send their, you know, a grandparent or parent or somebody who maybe might have a little bit of dementia or might be confused. And certainly on a case-by-case basis, we are allowing some, but I think just better messaging and education to our communities could go a long way.